So it looked like the count in the room yesterday when we asked about NPs, PAs was a fairly high percentage. Could I see the hands again, NPs or PAs? So a lot. So I'm hoping that this discussion is actually discussion and not just me talking, because there's not actually all that much in this paper as you read through it, and I think it'd be more interesting to turn this into more of a conversation. And I thought even from the beginning of the talk, it's issues concerning the PA, NP, and the ED. It kind of reminded me of like Leave It to Beaver. It's like, Ward, can we discuss the beaver? We've got troubles. And I think at least in my department has used PAs for, I think, 30 years or close to it. We were one of the first in Colorado to employ PAs, and back then, a lot of other emergency departments in the town looked at us somewhat askance. But obviously, 30 years later, we've had great success, and almost everybody that I know is using PAs and NPs. But it does bring up certain topics and issues, one of which, as this paper points out, the first question is, what do we call you? And we often use the term mid-level, and I was somewhat surprised, actually, that that is not considered an appropriate term, if I guess we're trying to be entirely correct. But I am curious if there's feeling in the room amongst PAs and NPs that mid-level is somehow an inappropriate term and you take insult with it. Any thought about that? I'm getting one shake of the head. Does anybody actually feel like, please don't call me a mid-level, I am an advanced practice provider, which is what we're told the collective term is preferred to be. Do you prefer to being a PA, NP, or an APP?
I've never had a problem being called mid-level. I know that a lot of times our medical director will say, oh, I'm sorry I call you guys mid-level. So I'm like, why are you, it's never bothered me.
So nobody really cares that much. It's not a particularly hot topic that burns up the...
I don't really care personally, but if I get called that in front of patients, sometimes they're like, wait, why am I not getting the top level provider? So there is that.
Well, it would seem to me from a patient perspective, advanced practice provider isn't saying all that much either, but I guess individually people prefer, I'm an NP, I'm a PA.
In our facility, which is in a rural area in Maine, we've used mid-levels for many, many years, and they are either NPs or PAs, and they use the term individually. My big bugaboo is with the term physician's assistant with an apostrophe S, because we don't belong to a physician.
Right.
PA. I don't belong to the physician, and I'm not the physician's assistant.
Yes, it sounds like...
a physician assistant.
Right, yeah, and that was clearly pointed out also in this. It's not physician's assistant, like, can I have a cup of coffee while you're at it, or it's a physician assistant. Just to make things a little bit more confusing, some of you might have heard this, there's a new law in Missouri that will allow medical school graduates with no postgraduate training to now become licensed under the term assistant physician. So Missouri will have assistant physicians and physician assistants, not to be confused, of course. The point of their existence is to service more rural areas, but the Physician Assistants Society, SEMPA, has made their displeasure with this terminology known. And I'm not sure I particularly want to be the patient taken care of by just a medical school graduate. Let's see where we are. Question, what forms of supervision exist for advanced practice providers? And there's two ways of looking at this. One is on the legislative side, and one is on the hospital side or wherever you work. About half the states in the country no longer require any kind of agreement between an NP and a physician, so NPs have been freed in many states to operate independently. PAs still have a supervisory arrangement with a physician, but often, and especially in rural settings, it's a remote and a retrospective type of agreement that many places require that the physician be somewhere within about a 30-mile radius. And then at some point in time, but certainly not contemporaneously, the physician has to review the documentation of the PA. I think for most of us who work in more urban settings, we're side by side with the PA or the NP. And so that type of agreement gets changed when you and the PA-NP and the patient are all in the same area. It still leads to 3 different types of supervisory options in the ED, and we use all 3. So there's the direct supervising, where not just the NP or the PA, but the physician also sees the patient and does some kind of direct face time with the patient, which can be fairly superficial, but it's largely for billing, but there also might be, of course, a communication and a quality issue as well. As Greg Henry has pointed out, he tries to see everybody, and he often walks. Do most people know who Greg Henry is? So if I do my Greg Henry imitation, it'll be appreciated. So I talked to Greg about this topic, and he says, I always walk in the room and say, hi, I'm Greg Henry, I'm the old guy. So his mostly is he walks in, he does a handshake and some kind of quick 20, 30-second thing, but oftentimes it's a much more detailed evaluation as well. And so that's the top level, direct supervision. There is indirect supervision with consultation and indirect supervision without consultation, and it's largely what that sounds like. So the PA or NP sees the patient and then reports back to the supervising physician in the with consultation, and then in the without consultation, the PA or NP is just seeing the patient independently, and later on, the physician signs the chart. So I'm curious what kind of working arrangements people have largely here. What do you do in rural Maine, or are you on your own?
Well, I used to be on my own, and when we got a new CEO, he decided that we had to have 24/7 physician coverage. So after having practiced flying solo for many years in the ED, all of a sudden I had a backup doc. And so sort of experimentally, I started consulting with the backup doc when I was at all baffled about something, and discovered that the backup docs didn't know much more than I knew.
Yeah.
And they too were baffled by the same things that I was baffled by. And I guess from a medical legal standpoint, it's nice having the one site, but they don't really directly supervise. They do a chart review once a month.
Yeah. Are most PAs, NPs working directly, consultating real time with their supervising doctor? I'm getting largely yeses. We recently opened a new hospital in December, and then we finally had a physical area for a fast track. And so we've now implemented those patients in the fast track are taken care of by the PA, and we sign the chart later, but only if the PA has questions do we hear about the patient in real time.
We've never used NPs or PAs because of our concern about malpractice liability. I work here in San Diego, and we have colleagues in other places in California who have no consultation. The NP/PA will see patients, send them out, the physician will sign, and they're now medical legally liable for this. So how do the rest of you solve this in 5 malpractice insurance states?
Yeah, the malpractice issue is one, let's just defer that until we get to it, which is just down the page, but that's probably the most meaty topic on here, and I think it's very interesting. But let's cover that in just a little bit. So for the most part, the degree that the PA or NP sees patients, whether they consult, and how much they can do in the department is largely determined by your local environment. It's basically what you've all agreed to. So it's not legislated. Generally, hospital credentialing departments don't have that much to say about it, although PAs and NPs have to be credentialed. But it's basically your own group's work environment that you've decided this is what we do. And I think For most people, it's a tacit arrangement. So there is rarely a written guideline for this is what the PA can see, and this is what the NP can see, and this is what they can't see. And the last time I gave this talk, there was nobody in the room that worked in a department that had that type of outline, that, oh, I can't see that patient, you've got to see that patient, but I can see that patient. So is there anybody in this room, what's your...
I'm a small rural Alexis hospital that I work at, and our mothership has certain rules. Pretty much just, if it's a cold flu, the doc has to see it, or if it's a common flu or stroke.
Okay.
Other than that, it's kind of individual. I feel comfortable with X, Y, and Z. Maybe my other NP doesn't. So, and they get to know you, and almost all the docs are happy with us working up to our comfort level.
Right. So I think that's how it is almost uniformly. She was saying high trauma, a code arrest or a stroke has to be seen by a physician, but otherwise it's do what you're most comfortable with. And if you have questions, obviously, come and talk. We, years ago, in my department, tried to figure out specific diagnoses, chief complaints that a PA could see. And we quickly realized that there is no such thing as a bulletproof chief complaint. So you can think of anything, you can think of sore throat. Oh, well, sore throats are sore throats, but then there's, of course, retropharyngeal abscess and epiglottitis. And any complaint that sounds minor on the surface, there's always that, 1% risk that it's a really bad thing. And I think you can argue that the higher skill is in picking out those diagnoses amongst the sea of nothing, whereas the STEMI patient, I could teach a medical student in half an hour how to take care of the STEMI patient. It's largely call the cath lab, so we know how to do that. We can do STEMI in 20 minutes, get them in, get them out, but it's, sorting out this kid is the one that doesn't look great out of the 100 others I've just seen with fever. So I think clearly trying to figure out the lowest chief complaints and shunting them off to the PA or NP, that's fraught with all kinds of issues, as it would be if anybody tried to do it. And I think what might work better, similar to what you're doing, is maybe you pick a few things that has to be seen by the physician. So, I think old patient with abdominal pain, maybe 2 people should put their hands on that abdominal pain, because there's been literature that somewhere between 10 and 20% of old people with abdominal pain have true pathology. I mean, really sick, 9-10% mortality rate for old people with belly pain in some studies. So maybe that would be a good one to get a consultation on and have those kinds of rules. But effectively, almost nobody has those rules. So one of the things about the medical legal issue is that when you don't have rules, then everybody is somewhat liable when the lawyers come hunting. So if you say, oh, well, by design, the physician didn't have to be involved in that case, that would provide some degree of protection, but almost nobody has that.
So are you saying that the most senior physician belongs in fast track, where they won't miss anything?
No, I'm just saying it's a jungle out there. But I'm also saying that there's no such thing as making it safe, that, we'll just do these minor complaints.
We don't have any restrictions on what we can see, including codes and arrests and so forth. But just in general, I find that my consultants, my specialty consultants, are really, for the most part, more substantively helpful when I have a question or need an advance level.
Gee, I'm cut to the quick. I don't want to hear the consultants are better than the ED attendings, but that's what you're saying.
I love my ED attendants. They're wonderful. They're great people. And I'm not trying to denigrate what they know, but if I run up against something that needs more than I can provide, the consultants are more likely to be able to
That would make sense. I mean, that's essentially the role of the consultant. We did have a rule, and I don't know if it's still in effect because I put it into the effect when I was director of our department, and it sort of hovers out there. But speaking of consultants, we had a rule that before a PA or NP called a consultant, other than orthopedics, that would be a patient that they consult the physician on, because at least in our field, our area, there were consultants who, if they didn't like the presentation, and it just could be because they don't want to be consulted, but if it happened to be the NP or the PA calling, they'd say, who's your attending? Has your attending heard about this case? And so we made it a rule, largely so the PA or NP didn't get so much flack, that, you know, before you call the consultant, let's talk about the case, so that at least you got the backup, so when you do get the crap from the consultant, we're on the same page. And similarly, I ask that before you order central radiology testing, before you get a CT scan, something like that, I'd like to hear about the patient, because not only are you investing a lot of time, but not only a lot of money, but a lot of time. So, you know, the PA or NP orders a CT scan, that's a 3-hour investment of time, and at least I order a lot fewer CAT scans than a lot of people, so I'd like to hear about it. This paper does talk about there are various levels of advanced training which are not terribly well formalized in the NP-PA world, but PAs can go on and get certified for emergency practice, and there's actually a certifying test. NPs have a curriculum that they can go through, but it's largely on-the-job training, and there's no certifying test. One of the questions that comes up a lot is what kind of billing you get when an NP or PA sees a patient, and it's basically 2 levels. Most people probably do know this. It's either 100% billing if the physician has direct patient involvement, or 85% billing if not. So if it's consultation but no direct involvement with the physician, then you can only bill from professional fees at 85%. And so that certainly in fee-for-service departments, which my department really isn't much of, but in fee-for-service departments, the physicians often want to go see everybody, not because they're worried about the PA-NP quality of care, and not so much because they are worried that the patients want to see the doctor, but just to get that extra 15% billing. So are there people in here who the physicians are, I want to see that patient, I want to see that patient to get the 15%?
Yeah, we have a handful who are like, we're just popping in. They will literally open the curtain and like wave at the patient and count. They want their RVUs or they want that 100%.
Yeah.
Case they need. Like they don't even do anything. They just show the face, like the patient saw their face for 1 second.
Right. Yeah, so clearly not a quality of care issue there.
And you
Hi.
know who they are, you know, when you're working with them attending, and it doesn't bother me, but
Yeah.
it's often asked, like, who's that?
The shadow in the night. Who is that? Other comments on that? I think it again, the medical liability thing is, I've certainly heard of cases where the physician, and it's the PA being sued, says, you know, I wasn't involved in the case. I didn't know about the patient. And it's like, oh, but you billed at 100%. So is it fraud or are you liable? So you got to be careful with that, because if you're billing at 100%, it means like I had direct patient involvement.
One thing I wanted to emphasize about the medical legal issue is the communication that the PAs and the NPs have with their supervising physician. Sometimes it can be a point where the physician really wants to have no interaction with the PA, and other times the physician wants to have a lot of impact on what the PA or the NP is doing. And so I think when we're talking about medical legal issues, a lot of times you have to understand that there has to be a very good line of communication between the PA, the NP, and the supervising physician. And I understand that it's very difficult for that to happen sometimes in a busy ED because the physician is also seeing patients independently. But I think we get into a real hard line with medical legal issues when the PA or NP does not feel comfortable coming to their supervising physician if there's something that they're concerned about, and vice versa. So having that communication is very important if you are an NP, and PA, and NP.
The complaints I've heard mostly are right along those lines, that it's not so much that the PA failed to tell the physician, but it's the physician didn't provide the level of supervision or consultation that the PA or NP was actually wanting. It's like, I was worried about this patient, I went to see the attending, and the attending is like, yeah, sounds good, whatever you want, I don't want to get involved, I'm too busy. And that's probably more where the liability lies.
I think that's largely up to us to speak up. You know, I don't ever have a problem, whoever the attending is, whether they're really nice and everyone knows they help the PAs all the time, or they're kind of known to be an asshole, they don't like to do anything. You know, if I have to go talk to them because I'm worried about someone, I will make sure I get the response that I need. And I think that's up to everybody who's seeing their own patients to do that.
Yeah.
You know, like you can't just say, oh, well, they just passed it off, whatever. Like, if they're blowing me off, I'm actually worried about them, then I'm going to continue that conversation.
Yeah, in my department, the concern has been not so much, in fact, hardly not at all, with the PAs operating independently. It's the physician side of the supervision. It's like, really, if they're asking, you got to go see. You can't just push them aside when they are asking for the help. But by the same token, like most people are saying, when the PA or NP is feeling comfortable, then probably the physician involvement adds very little to that. Oops. Let's see, credentialing, I'm not going to really cover, but the hospitals do the credentialing. And they have to be credentialed unless the physician, the PA or NP, is just doing specific procedures, and in that case, acting almost as the physician's assistant, where the physician says, I saw the patient, turn your brain off, but go sew that laceration. And if they're ever in a department where they don't do any clinical diagnosis, decision-making, and all they do are procedures, they don't have to be credentialed. I don't know anybody who uses NPs or PAs in that manner. So a little bit more on the medical legal side. Why don't you bring up your question again?
My question is exactly, I guess, that. If you're going to go 100%, then you're taking medical legal responsibility, because that's what you said you're going to do. I'm a little bit uneasy about having folks seen and exit in California that I've not even told they're in the department, have, you know, that the NPPA seen them over in this room, and I'm seeing patients in this room, and never the twain shall meet. I've worked with some excellent NPs and PAs, but I'm a California girl, and I just feel uneasy with that.
Are there other attendings here who... I'm sorry, it was basically, she's uncomfortable with the notion that you could have an NP or PA working over in a corner here, she never hears about the patient, never sees the patient, and then yet is assuming some kind of medical legal culpability should something go awry.
And I'm signing a chart for somebody I never saw.
And is signing a chart for someone she never saw.
Do you have to be a supervising physician if you're working and the PA is working simultaneously?
You don't have to be, because at least in Colorado, and I think it's fairly uniform, the PA is assigned a supervising physician administratively. So I have 3, I think. And I could be that physician assistant's supervising physician on the patients that they're seeing. And the regulations, again, are not that it's contemporaneous or even consultatively contemporaneous. I could get the charts and sometime within the next 2 weeks sign them. But I think most people who work in a department where everybody's operating in real time would say, no, the guy on duty is going to be the one supervising the PA on duty at that time.
So that could be organized in your organization. You could put it one way or the other. Is that accurate?
Yes.
It may be a little bit different by state, I guess, but in Maine, for PAs, there's a primary supervising physician who, in our case, is the director of the ED, and then secondary supervising physicians. And if you come on board as a physician in our ED, you have to sign on to that. And that's pretty uniform throughout the state in the situations where there are both PAs and NDs on
Yeah, she's saying there's primary and secondary, and that's essentially the same thing, that the primary is often just the administrative person who every 6 months signs some kind of form that says this person's competent. But the secondary ones are the ones on the front line with the person who are working and signing the charts. At least that's how it is with us.
In Boston area, just south of there, busy week, but I don't know if it helps to be medical legally as an MD. PAs, they have somehow electronically brings in the charge physician at the bottom of the chart. Dr. Singari is available for consultation. Glaser was not consulted. It's a checkbox. They have to check it before they can sign it. It's one of those points where they cannot sign a chart until that box is clicked. And then they're supposed to put a little quick blurb, they could check it and say, I consulted him. And that kind of puts it on my radar. And if you don't see a billing or another comment by me, that's going to be an 85% billing, 100% for RVs and cost of care. But that puts me on that legally notice. And whether that protects me to some extent, that box is checked, I did not consult him. He was available but not consulted. I'm not sure. It hasn't played out yet for us.
Yeah. The question is how much liability you assume by just checking the box saying, yes, I understand this.
No, it's not that. It's the PA actually checking the box, saying Dr. Singer is available, was or was not consulted. And that puts me, if I was consulted by practice, I make myself available to the patient.
Yeah. I think Ken Clower, who wrote this chapter, is a JD as well as an MD. And he feels that if you've got some kind of attestation on the chart to that effect, that the physician did not see this patient, I operated independently, that does shield you significantly. But of course, in the medical legal world, anybody can be sued. So the question ultimately would be, were it to come to jury, would the jury see it that way? And it would seem commonsensically that if the PA is saying, I never talked to the physician about it, the physician never saw the patient, you would imagine that would provide some degree of protection, but it's going to be on a case-by-case basis. Other comments?
We have 3 checkboxes that we have to check before we sign it. We can either check that we saw the patient independently, that there was a physician in the department. We can check, we discussed it with them, or we can check that they had face-to-face time. And then I put a blurb in depending on which box I check. And
Yeah.
I think on our side, as nurse practitioners, it's important to know that, if we're making these big decisions, we should be having these conversations. And we do basically what you were saying. If we're doing CT scans, if we're consulting, if we're, I feel like it's important. And it's important when we bring people into the department as an adult so they understand this is how we function. And if no one has that conversation, then we can end up with kind of strange.
Yeah, there's certainly there's a learning curve for every department when the PAs and NPs are in there that like this is how we do things around here. And then for most charts, there will be some kind of attestation either by the physician writing it or the PA/NP writing it about the level of involvement. One of Greg Henry's other points when I talked to him was, in the jury would be, so doctor, you were 10 feet away from the patient and you never took the time to go and see him? And he said that doesn't necessarily look so good to a jury. But it's reality, and many argue that if I had to go see every patient the NP and PA saw, and actually see the patient, not these sort of, hi, how are you? Then really, what's the point of having them? It's got to be an increased productivity. So the challenge, of course, is finding this is the patient I've really got to go see, but this is the patient I don't really have to go see, and that's a real art.
So we're just trying to establish a PA program in our shop, and what I hear is even if you're not legitimately the primary supervising physician, all the physicians need to be on board with the idea that you could be asked to walk into a room, and you are going to be responsible for patients the PA is seeing, whether or not that's a PA that you're formally supervising. Is that accurate?
Again, I think there's that primary assignment that everyone has like their 2 or 3 that they're the administrative supervising physician, but then there's the real-time supervision. And so your group has to work that out. Now, I mean, it's similar in my department. We also have residents. And there are some doctors that say, I don't want to work with the residents. And so we can structure the schedule that they don't work with the residents. So it would seem possible that you could also, if you really had physicians who said, that's great, I just don't want to do it, you could potentially do that. But it adds a level of complexity to your staffing that a lot of people just don't want to deal with.
It's a matter of trust that needs to be established. You get to learn each other, but I think there's certain guidelines that when a facility or the doctor group hires a mid-level, that they're going to have some competency and there's going to be some kind of trial period. And then after a while, they're going to, as they check, they'll understand that you know what you're doing and you know what you don't know.
Yeah, she's talking about level of trust that obviously makes this relationship work. In the back.
So I'm one of the attendings to a suit. It's on a PA patient, and there was no quality of care issue as far as I'm concerned with how the PA evaluated the patient. I never saw the patient, and I did a routine signature. The issue we had is I was from a large academic university medical center, and we were staffing at part of our residency an outside community facility, which is where I was, and my lawyers were from the university, and their lawyers and their employment was from the other hospital. And what you run into if you have two separate groups is the PA and I didn't have any disagreements about anything, but the lawyers are trying to point at each other as to how to have trouble. So be really careful when you set this up as to how it's set up. You want to have the same legal team. Otherwise, it's the same as you against the cardiology service or whatever. You want to have the same support structure there, because it becomes dueling lawyers, each trying to put blame on each other, so where they really actually.
That's clearly a no-win situation, except for the plaintiff. That if the plaintiff attorney can get someone to say it's his fault, and it's like, oh, good, we got fault established, and then let's go from there.